Good afternoon. My name is Amy Smellers, and I am Director of Healthcare Education and Professional Development at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Patients as Payers, Addressing the Patient Affordability Gap. A few logistics before we start. If you have any questions, please put them and use the chat feature for today's webinar as we are in listen-only mode. And the questions will come directly to us, and we will do our best to get them addressed during and at the end of the presentation. I also want to take a moment to thank MHA's 2024 sponsors, as well as our strategic partners for their support in underwriting today's webinar, which is just one of the many events that we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I'm pleased to introduce our speaker for today from AblePay, Ryan Whirling. Ryan is the Senior Vice President of Business Development at AblePay and has been with them for over 6 years. Prior to his role at AblePay, he was the President and Chief Executive Officer of Mac Defense, a wholly owned subsidiary of Mac Trucks Incorporated. Ryan also served in active duty from 1996 to 2008 and is now a retired Lieutenant Colonel in the U.S. Army Reserve. So Ryan, first, thank you for your service and all that you've done. And also thank you for being here today. And I'd like to hand it over to you.
All right, Amy, thank you very much for the opportunity today. Again, I'm Ryan Whirling, Senior Vice President of Business Development. And before I start, I did also want to introduce my teammate, Heath McDaniel, who's our Regional Sales Executive in the Northeast. So Heath, if you could quickly introduce yourself.
Good morning, everyone. Heath McDaniel, as Ryan said, Senior Vice President for Providers in the Northeast. Enjoying that we're going to be able to provide you with some information on our program. And just a quick footnote, I'm working with multiple health systems, MHA providers. So look forward to getting any feedback from you on this presentation.
All right, thank you, Heath. So, Amy, I'm going to go ahead and share here. Just to make sure, can everyone see that? Amy, is that okay?
Yes, perfect.
Okay, great. So again, good afternoon. Just a little bit about us. So we are, our corporate headquarters is in Allentown, Pennsylvania. So those of you that are seasoned like I am probably know the Billy Joel song, Allentown. And you're welcome, because if you take away anything from this webinar, it's going to be that song in your head for probably 48 hours. And if you're not, I can send you the YouTube video afterwards. But again, corporate headquarters in Allentown. Our founder and CEO is a former health system CFO. So I think as we go through a high level, overview of AblePay, you'll really see how this program was designed through the lens of a CFO. John, our founder, was a CFO at age 28, so came up really quickly on the provider side, really in trying to come up with something that was easy and that was really going to help not only hospitals and health systems, but also the patients, which makes us really unique. So I just wanted to share just some of our sample partners across the country. We are in 26 states now. And a couple of things I just want to note, you can see we have very large systems. So systems like Penn Medicine in Philadelphia and the Lehigh Valley Health Network. We also have critical access hospitals and orthopedic groups. So I think what was really important to John was designing a solution that could help providers of all sizes. And I think that's one of the reasons, we were able to partner with the association as a strategic business partner, because we're willing to help providers of all sizes. The second thing I'll note is all of these providers were previously using something before we came in, whether it was a banking solution or an early out. And as we walk through the program, I think you'll see that we're just another tool really in helping providers, attack this out-of-pocket collection problem. And I just wanted to note, also, in addition to Massachusetts, you can see we have other hospital associations in the Northeast where we're endorsed, including New Hampshire, New York with Haney's, HAP with Pennsylvania, and then we are in 18 state associations across the country. They've really chosen us as the solution to help their members. And then I'll start with I don't know if any of you are familiar with this, but the Consumer Finance and Protection Bureau came out with an RFI in July of last year, really addressing, the dangers and some of the negative impacts of medical credit card programs. So you can see some of the highlights here. I am going to ask Heath is going to put the link in the chat. If you're not familiar with that, he will put that in there, but you can read about it. It's a significant issue. And I think, with the way patients are treated, and again, that's one of the reasons Massachusetts and these other state hospital associations chose us, because, the way we're addressing that affordability gap, but I think most importantly, the way we treat patients. And then I know this slide is a blinding flash of the obvious, but patients can't afford to pay. But I think it's, and I'm sure you're hearing this all over, but I think it's important to dig into this. 7 out of 10 of Americans have less than $1,000 in savings. 2 out of 3 are avoiding care because of cost. And as we know, when you avoid care, you're going to need more services down the road, which continues to just compound on that problem of patient responsibility. And 4 out of 10, so imagine of the 10 patients that are walking into your facilities today, 4 of them already have debt, whether it's with a bank, whether it's with a medical credit card, whether it's with friends, whether it's family. So they're already, 40% already have responsibility that they're trying to pay off. And then the number one reason today for bankruptcy in the United States are unpaid medical bills. And then the process is very confusing. So I would say if all of us could get together, try to design a process that's more complex for a patient, we would probably fail. But I'll tell you a personal story. So before I joined Able Pay in 2017, like Amy said, I was selling armored vehicles in places like Tunisia, and I was in the Army. So probably the worst candidate to ever come to healthcare, but our founder and I were good friends. We coached basketball together. I joined the team. The first week I went to John and I said, John, you told me this was hard. This stuff's really easy, but I don't know what co-insurance is. So as you can imagine, he said, first of all, you're not very smart. I made a mistake. It's pronounced co-insurance. But I will tell you, I'm not embarrassed to say that, because as you look at this chart, I think what really sticks out here is 48% of people do not know what a copay is. Those have been around for decades. Half of Americans have no literacy at all. And you can see they don't know what counts toward a deductible. They don't know what procedures are covered, and that leads to a really bad patient experience when people don't understand, and then they don't pay because they don't trust the process. And then providers are losing revenue. So obviously value over time goes down, cost to collect goes up. 3 out of 4 don't pay within 1 month. And then, almost 7 out of 10 hospital bills under $500 were not paid in full. And there's a significant cost also when you're sending out statements, right? There's a cost to that, and that's degrading the overall profitability of what a patient owes. And then we did want to point out, because Heath has been in numerous conversations with MHA members, the national average on collection percentage on patient responsibility is about 30%. Based on all the discussions Heath is having in Massachusetts, that's around 40. So you're definitely higher than the national average. We typically find that in the Northeast, that patient responsibility collection is definitely higher. I had a call with a hospital in Arkansas. They were collecting, 9%. So again, it's a significant problem across the country, but we do want to highlight that we understand Massachusetts is definitely a little higher than the national average. And then you throw all of these things together, the patient experience suffers. So 3 out of 4, again, are confused by EOBs or their bills. 9 out of 10 want customized payment plans. And, almost 7 out of 10 will actually consider switching providers for a better payment experience. But I think, the most interesting bullet that sticks out on this slide is that last one, that there's a 30% decrease in satisfaction between discharge and the billing process. So all of you are very good clinically at treating people. But again, it goes back to the fact that people don't understand. They don't know how it works. They don't realize that they spent 2 minutes, choosing their high deductible health plan during their open enrollment. And now they have an $8,000 family deductible and they have a $5,000 bill. So again, and you're probably not getting calls from patients that say, hey, the bill you sent me was really timely. I totally understood it, and just thank you for sending it to me. Now, maybe you are, but again, that all goes back to the fact that patients really don't understand how the whole billing process works. So I'll get into Able Pay, and we'll walk you through a really high example. And then I think most important today, we're going to share 3 case studies of 2 providers in the Northeast, 1 in the Midwest, that really address, this payment, patient payment behavior. So there's really 2 sides of our program. One, there's a provider side. We refer to ourselves as the next generation patient financial engagement tool, dramatically increasing patient revenue, the efficiency in which it's collected, and the overall patient experience. But what makes us really unique in the market is that we're addressing this affordability gap. So we're providing savings on patient responsibility to patients, flexible terms, and we'll walk through an example, but all of these terms are with savings options or 0% interest. We advocate for patients when they don't understand something. So this is not customer service. This is a team that all sits in Allentown, Pennsylvania, that's not offshore, that's not outsourced, where we're taking calls from our members or your patients and we're explaining the bill to them, which goes a long way in building that trust. And as you know, you build trust, people are more likely to pay, and we make it really easy for patients to pay their bills. So I think that the easiest way to explain Able Pay is to just walk through a high level of how the program works. So it starts by signing a contract with a provider. It's a very simple agreement. It's a page and a half where we are agreeing to a discount on the patient out-of-pocket responsibility for the provider to receive a payment within 14 days at no recourse. In our contract, we know in Massachusetts, the Hospital Association and members are very sensitive to how patients are treated. We do follow the 501(r) rules of collections in our contract. Those are the IRS guidelines for nonprofits. And then we do accept all patients automatically without credit checks, without propensity to pay scoring. So I talked about that CFPB inquiry that Heath put in the chat. We're really the antithesis, and that's one of the reasons Massachusetts selected us, because of, again, how we're addressing this affordability gap. We then work with a provider to offer Able Pay to their patients. So you can think of this in three buckets. You can think of pre-service, time of service, and post-service. So pre-service could be a patient text message that goes out. You can save money with Able Pay. Here's your enrollment link. On the finance page, on the MyChart page, where there's opportunities for patients to learn about the program. And then time of service could be a business card that's handed out with a QR code that drives them to a landing page, or a trifold brochure that explains to a patient. And then post-service, what's really powerful for us is including a stuffer or an inline print with the bill. Patient, you can save money on this bill. Again, so now we're hitting the patient when they need us because they have an expense. We're helping the provider at the same time, while at the same time helping the patient. And then patients enroll, and they're gonna come and show their cards. And just to show you, this is what the Able Pay card looks like. There is no money on it. This is not an HSA card. It looks just like an insurance card. You can see on the front is the member name, their ID, and you can see on the back is that payer ID. So when, working with Able Pay is as easy as registering us as a secondary payer, because we're using the existing rails of how the insurance process works today. So I'll use an example. I'll use Heath, and I'll use the Lehigh Valley Health Network here in Pennsylvania. So Heath is going to go to the Lehigh Valley Health Network. He shows his Blue Cross card or his Aetna card or his United card. We're agnostic to the primary. So I'll stick to Blue Cross. That's the dominant here. Heath shows his Blue Cross card. He also shows his Able Pay card. So Lehigh Valley is simply putting that in the secondary position, just like they would any other secondary insurance. Charges go out to Blue Cross. It's a $10,000 charge. $5,000 is the allowable. But in this example, we'll say that Heath has a $1,000 deductible responsibility. Lehigh Valley is still going to get 4 of the 5,000 from Blue Cross. Able Pay does not interact at all with that primary agreement. Where we intercede is on that $1,000 that Heath owes to Lehigh Valley. Because we're in the secondary position, we're going to receive that claim via an 837. 835 is going to go back to Lehigh Valley within 14 days at our contractual rate, which for providers is 30%. So $700 goes to Lehigh Valley in 14 days with no recourse. Heath is off the books. We've removed all the patient, and now that's a complete risk shift to Able Pay. But then what happens on the patient side is we send Heath a text message and email. Heath, you have a $1,000 bill at Lehigh Valley Health Network. What do you want to do? So then we send our member Heath a text and an email. Heath, you have a $1,000 bill at Lehigh Valley Health Network. What do you want to do? So as you look on the top left of this slide, Heath has really 5 choices to pay this bill. So if he has the money up front, which as we know, 7 out of 10 have less than 1,000 in savings. But if Heath does, he can save up to 13% on that bill with a checking or savings account, which is an ACH transaction. Or he could save up to 10% with an FSA card, a Visa card, an HSA card. And the difference between the delta of the 13 and the 10, as you see, going down the options, is the swipe we have from our vendor. Or Heath could save up to 10% over 3 months, 8% over 6 months, or you can see from 12 to 24 months, he doesn't save, but there's no interest. So on every single claim, Heath decide what best meets his financial situation or his family's financial situation, and he can choose on every claim. So we're not aggregating things together, and our members really like that because, again, gives them the flexibility to choose, based on every claim. I talked about the advocacy, but our founder, as a former CFO, that was really important to help people navigate. So again, this isn't customer service. This is advocacy support where we're answering questions, we're explaining deductible, co-insurance, copay, non-covered services. We're covering all that. That's a really important part of changing patient payment behavior. And then again, we make it really easy for patients to pay. And then I'll switch to the provider side. So we are going to share 3 case studies where we've documented increasing revenue per patient, and new revenue, the efficiency, really going back to the example I walked through. It's easy implementation because I'm sure all of you on the call today are processing secondaries or processing tertiaries. That's how we're interacting with the current payer rails, getting paid faster with that contractual rate that we agree upon in 14 days. And again, this is a no recourse program, a complete risk shift of that responsibility and risk to able pay. But again, we do follow the 501R. We have never sent a member to collections. We have written it off as bad debt on able pay. Patient experience, I'll show you a case study. And then again, we're reducing all those costs. So, we're eliminating the paper statements. And I will mention, you can keep all your current processes and vendors. You don't have to get rid of anything. We like to say we're just another tool in the toolbox to help providers. So Amy and the team, I'm just going to pause here just to see if there's any questions from the group or anything that I haven't done a good job of explaining.
All right, no, I think this is great. I think one question that I did get on the private side of the chat was related to which you may have addressed, but just to double check, and how you decide which patients you allow into the program.
Yes, Amy. So we do accept all patients automatically. So again, we are not a bank. This is not a line of credit. And we're not going to go through the enrollment and portal today, but I think any of you wanted to schedule a follow-on, Heath and I are happy to show you that because I think that does bring it all together, but it's not the time or the place today. But when a patient enrolls, we actually don't ask for social security number. So again, no credit checks, no propensity to pay scoring. We accept all patients automatically. It's not an application. It's really an able pay enrollment because we accept all patients. Amy, any other questions?
Not right now.
Okay, great. Thank you. Okay, we'll move on. So on the patient experience, which is really important to us, when every patient enrolls in our program, we ask them 3 questions, and that's on the left. Once a patient goes through our program for the first time, we go back to them and we ask the same questions. So you can see we have a significant increase in all of these, but particularly the overall satisfaction with the billing process. And a lot of that is the advocacy that we do, right, in helping people navigate. But also the fact that, we're addressing, savings over time. And then we did a net promoter score last summer. We did it again. We have held at a 69. And just to put that into perspective, if you're not familiar with a net promoter score, healthcare average is a 38. So we're almost double. And also Starbucks has a 74. They serve, what can be very complex coffee orders. We advocate on very complex medical bills. So we're really proud of that experience. And then we're really just an extension of our provider partners because that patient experience is coming from them to us because that's how they're learning about a program is from their provider. So I'll take you through 3 case studies. And I think I know people really like to see the case studies because it shows that we are changing patient payment behavior. St. Luke's was our first health network. We have been under contract with St. Luke's since 2017. This was the first case study. So it was really important to us. And our founder, John, would tell you that, this case study was really going to prove, are we changing patient payment behavior? Because if we didn't have these results, he would have shut the doors down and we would have said, hey, we just weren't able to do it. So a really unique case study. So with the methodology, on all the patients that we paid them on in 2021, St. Luke's sent us the payment history on all those patients prior to joining AblePay. So now we're really comparing apples to apples. So how did patients perform before joining AblePay and how did it work afterwards? So as you look, 47% of those patients paid at 70% or above. So we do have patients sign up that are paying 100%. However, as you look, 20% is between 10 and 60. 32% of those patients were previously receiving bills from St. Luke's and they weren't paying a dime on those to St. Luke's. 23% was bad debt, and it was taking St. Luke's 111 days to collect the money. So as we look performance before, performance after on this aggregate population of patients, we increased their overall collection rate by 49.4%. We also saw new revenue. So the new revenue is not built into that 49%, but these are patients that had never gone to St. Luke's before. They might have heard about the program from their friend or their coworker, and they signed up for the program. But I think most interesting for those finance professionals on our webinar today is that revenue per patient went up 41%. So what does that mean? That means that the payments from the payers increased, which we know is significant, along with the corresponding balance after insurance payments from AblePay. Days to collect from 111 to 14. So they're getting more and they're getting it quicker. And then we did pull out patient net promoter scores that they gave to us specifically for St. Luke's. And we had a 92, which we're very proud of. So a significant, obviously this was our first one, but I will transition then also to the Lehigh Valley Health Network. So if you're not familiar with Lehigh Valley, also here in Allentown, Bethlehem, Easton, and in the greater Lehigh Valley area. Both St. Luke's and Lehigh Valley are 3 billion plus systems. But again, same methodology with Lehigh Valley, comparing before, comparing after. So you can see a little bit different of a story at Lehigh Valley. So 57% of patients, 70% or above, but almost 38% were not paying anything on previous bills. Bad debt was 23%. And it was taking them 97 days to collect that money. So overall, again, as we look at that aggregate collection percentage on patients before and after they joined AblePay, collection rate up 47%. Again, we saw new revenue, and that, again, is not included as part of that 47 patients that had never gone to Lehigh Valley Health Network before. And again, now our second case study where we're showing revenue per patient up over 40%. So again, drives up payments from the payers along with the corresponding balance after insurance from us. Days to collect, 97 to 14. And again, we pulled out those patients, 89 net promoter score for Lehigh Valley. So really, really proud of these results. And then I want to share a third. So this is unique. Ephraim McDowell Health is located in Danville, Kentucky. It's about a 220 million net patient revenue hospital, but it includes 2 critical access hospitals. So again, we wanted to prove to Ephraim, right, that we were changing behavior. So again, same exact methodology with Ephraim. So as we look, this is a little different. So 49% was at 70% or above, but you can see 40% were previously not paying anything on their bills. Days to collect was at 111. So as we look before and after, again, with that same methodology, collection rate was up 106%. Again, a third case study above 40%. Ephraim is at 48%. So we've proven now through 3 case studies that with the protection of AblePay, patients can save, upfront. They can save over time, or they can stretch it out with no interest. Because of that protection on a claim-by-claim basis, they're going out and getting services they might have been putting off or delaying due to cost, and then days to collect from 111 to 14. There is something I wanted to highlight on this slide, though. As you look at that reimbursement at 70%, you'll see the 19.3%. So before AblePay, Ephraim was offering a 30% prompt pay discount on balance after insurance. Despite offering that 30%, you can see that 40% of those patients that enrolled in our program were previously not paying anything. And I think, again, that goes back to, the slides we went on the affordability issue up front. 7 out of 10 have less than 1,000. They couldn't afford that 30%, prompt pay. But what did help them was saving over 3 months or saving over 6 months or stretching out, from 12 to 24 with no interest. So again, a third case study that we're really proud of that shows we are positively changing patient payment behavior, for the good of both providers and for their patients in the communities they serve. So Amy, I'll pause here for any questions overall or any questions here on the case studies.
I guess actually one that has come in, and then I'll ask this one and let you continue on the presentation. But one is, do you have you had any restrictions on beds, on the number of beds on providers that you help?
Yeah, great question. So we have systems as high as Penn Medicine. We have a critical access hospital in North Dakota that's 7 million in net patient revenue. So I think we also have a single chiropractor in Pennsylvania. So I think, one of the reasons the associations, really like Able Pay is the fact that we can help all members. So there's no restriction, whether it's a critical access, whether it's a strong independent hospital, or it's at a large health system. Our program is really designed, and I think you'll see, really through the lens of a CFO from our founder being a former health system CFO, we've designed it so that we can help providers of all sizes. There's no restrictions.
Excellent, thank you. And I do want to have one other question here, and encouraging folks, if you have questions, to put them in the chat, please, and we will get to them. I think one other question that's come is, so if a patient enrolls in your program and already has an existing bill with a hospital organization, are you able to process that bill, or do folks have to wait until patients have the next service? What is that process?
Yeah, Amy, that's really, and that comes up a lot. That's really something that the provider decides. I will tell you, almost all of our providers across the country will allow a patient to learn about our program. And in the enrollment process, they can actually upload that current statement. When they're enrolling, what we do is then we request the claim from the provider. We receive that, and again, getting paid within the 14 days at our contractual rate with no recourse. But again, and as you realize, every 30 days that goes by, if you haven't collected, your chance of collecting really starts falling off a cliff. So again, it's really the provider decision. Most of our providers are open-ended. So if it's, a statement from 6 months ago or 9 months ago, they allow a patient to enroll, even on a payment plan. An example, Amy's on a payment plan and her balance is $330. Majority of providers will allow them to upload that, and then it would really go on the balance of what's left on the payment plan, getting paid in 14 days, with no recourse on that.
That's great, and actually piggybacks and leads into this. This other question is, what happens if a patient doesn't pay?
Yes, so in our contract, we follow the 501(r) rules of collections, right, which was really important to John and how we treat people. But those are the rules according to the IRS for nonprofits. So it's a series of calls, emails, and statements. But again, we have never sent an Able Pay member to collections. And I think it goes back to part of that explanation is, we're not buying Heath's debt from Lehigh Valley Health Network and chasing him down. A lot of, our providers wanted to offer this as part of their consumerism strategy, where they're bringing something. They want to bring as many tools as they can, but, patients are self-selecting. They're opting into the program. But again, on the other side of that, we accept everyone. So it's not like, we're accepting Heath at 780 and turning me down at 320. We do accept all patients automatically also.
That's great. And there is a question here. You mentioned that this can be another tool and we can continue to use existing process vendors. Where can we get direct savings on existing processes and vendors, possibly less statement costs and other cost savings that clients may see generally?
Yes, thank you very much. So you're using an early out today, or you're using a banking partner. That's great. We are not a rip and replace. And I explain that by because we're so far upstream in that secondary position with that secondary processing, it's coming to us via that 837, and you're getting funded, 835 ACH. We're upstream with anything, but let's just say that, Amy doesn't enroll. She's going to continue to follow through your normal process of how you have. So you can keep your early out. I will tell you though, just based on the question, we are also going to reduce some costs. So not only are we going to, globally increase what your collection rate is probably today with our contractual rate, but imagine you're no longer sending out statements. And as you know, that costs money. There's early out fees. So because those patients, and the great thing is once a patient enrolls, they're going to continue to use the program next month, next quarter, next year, if they have a spouse, if they have kids. So this is a long term, right? And then I will also mention, we do fund all of the marketing. So, we integrate with a statement vendor. So a provider, our partner, will link us up to their statement vendor. We actually fund the statement vendor to include able pay information in there. So this isn't an additional marketing line item budget. We'll print 1,000 brochures, send them to your facility. So all that marketing support is funded by able pay, including, messages on my chart or the finance page. We create all of that working with a provider's marketing team. So there's, the only way able pay makes money, and I'll kind of piggyback Amy on that, is the difference between, the rate we have with a provider. We share up to 13% with the patients and we keep the rest. There's no startup fees for a provider. There's no monthly fees. There's no annual fees. The only way able pay makes revenue is on the difference between our contractual rate and what we share with patients. So Amy, I hope I explained that okay for that person.
Yeah, I will say, not speaking for them, but that was really helpful answers to that question. We really appreciate it. And we are actually coming up on time for our webinar this afternoon. These always go really quickly, especially with all of the great content and information. So I would like to thank you, Ryan and Heath, for being here today, sharing this information and this content. And thank you all for joining us here this afternoon. And please scan the QR code on the screen. We have upcoming educational programs and several events coming up this spring. And also, as always, you will receive the recording and materials for this information along with the contact information for Ryan and Heath that they've shared today. And thank you all for attending this afternoon and for a great discussion.